I want to at least give you time to go to bed. Therapy-resistant depression. It's a very, very important area of psychiatry. And yet, oh, sorry,
It's distracting us.
It doesn't work?
It works, but it distracts us.
Does it?
It's
Well, can we turn it off? Turn it off. Probably that turns it off, yeah? How's that? Yeah? Okay, thank you. In spite of the fact that at least 30% of patients with major depression do not get well, there is no agreed international definition of therapy resistance. And that's this is a big problem in psychiatry. It happens in so many areas that clinicians cannot agree. And there's an enormous difference between the Americans and the Europeans and the rest of the world. Hence, we have two classification systems, DSM and the Americans, and the ICD system in Europe. So that they differ, even in terms of basic classification of major psychiatric disorders. So when you come to specialist areas like therapy resistance, you can see the problems we have. But these are two definitions which are practical and which most clinicians in Europe use. When major depression fails to respond to at least two antidepressants administered at optimal doses and for at least 8 weeks. The other general definition, an inadequate response to treatment occurs if the patient does not achieve full remission of symptoms. That's a broad definition, but I think it's probably the more accurate one. We have to get our patients well. So, no internationally agreed definition. Sometimes called difficult to treat depression, chronic depression, refractory depression, severe depression. You will see all of these in papers and textbooks and used by senior psychiatrists. An inadequate response to an adequate course of treatment in a patient with major depressive disorder. Gives a general view. So all of you as psychiatrists will be seeing patients, however you choose to define it, with treatment depression. It affects a very large population of patients. And remember, of all of the major psychiatric disorders, affective disorder is at the top of the list in psychiatry. And not only that, that by 2020, it will be the second major cause of disability in the world, according to the World Health Organization. A major cause of disability in the world. Just think of that. So, if one looks at the outcome, the prevalence rates, going in terms of treatment responses, inadequate treatment responses, in terms of stage 1, 50% of patients are still not responding. In stage 2, as far as you can go, 35%. And of course, these patients are suffering. They have a much poorer quality of life overall, not just because of their psychiatric illness, but because of their physical illness. They are a major problem in all societies. They take up enormous amounts of clinical time and cost to society. Now, if you have a very poor mental health service, this doesn't matter so much because the patients are not going to be seen and treated anyway. It's just the rich few. But in a civilized society, that's not acceptable. All patients, irrespective of whether they're rich or poor, deserve optimal treatment. That's what we should always be aiming for. Sorry, this is a very busy slide, but really there are guidelines. The American Psychiatric Association has a list of criteria which are very practical. What do you do if you have a patient that's not responding well? You make sure the dose is optimal. You may need to increase the dose. You add, change, or increase psychotherapy. But, of course, you have to be rich to get psychotherapy. You augment with other drugs. I'll be dealing with this in much more detail, particularly the second generation antipsychotic drugs. So this is really an important development in treatment. ECT, electroconvulsive shock. It is still one of the best treatments, particularly for resistant depression, therapy-resistant depression. I think you probably use it here quite frequently, yes? In my country it's used quite frequently. In the UK a little less. In Germany, not at all. In Holland, very restricted. So this is very much linked not to medicine, but more to politics and culture. Because undoubtedly, when appropriately applied, ECT for very severe depression is probably the best. I've always said, if ever I get really depressed, I don't want these nasty drugs with the side effects and so forth. I want ECT. Give me a good shock. It works. Okay. In some patients, adhering to dietary restrictions or giving non-monoamine oxidase inhibitors, which are very seldom used now because of the dietary problems, which I presume all psychiatrists know about. You don't, and particularly with the foods you have here in Turkey, which are wonderful foods, but probably full, many of them full of amines. So you blow the head off of a patient if they have a monoamine oxidase inhibitor with the blood pressure going way up. So now there are other considerations which I'll briefly touch upon. Vagal nerve stimulation, deep brain stimulation, and again the magnetic stimulation and so forth. I'll just briefly touch on those later. But these are approaches which you can use. Okay, treatment strategies. Despite all the limitations, the most acceptable objective data available today has come from the so-called STAR-D study, I'll explain that in a minute, in the United States, which involved thousands of patients, I mean thousands of patients, over many years, where basically they were all started on one drug, citalopram. You've all heard of citalopram? Yeah? Yeah? An SSRI, very, very commonly used. And then the patients that didn't respond to citalopram after 8 to 10 weeks were then given an alternative antidepressant. If that didn't work, they were given 2 antidepressants and so forth, right the way down to 4 antidepressants given at the same time. And still, there was a small group of patients that didn't respond. So this was the biggest and most intensive study ever done in treatment depression. Now, there's a lot of criticisms of it, but that's the best we have. So STAR-D, it means sequence treatment alternatives to relieve depression. Only the Americans could think of anything as complex as that. You know, and that's why most clinicians, including myself, and they can never remember what STAR-D stands for, but that's what it does mean. So you're not expected to remember it either. It's sponsored by the National Institute of Mental Health, involving 40 psychiatric and primary care sites in the United States. Enormous study. Citalopram, the first level antidepressant, failure to respond, followed by 4 stages of alternative treatment. So really very, very thorough treatment. And the outcome is shown here, and you can see how complicated it was. Level 1, patients didn't respond. Go to level 2, switch the antidepressant to bupropion, sertraline, venlafaxine, or alternatively augment citalopram with buspirone or bupropion. Now, buspirone is an anxiolytic drug which acts on serotonin 1A receptors. It's not an antidepressant at all. It's no damn good as far as I'm concerned. But anyway, that's what they did. And bupropion is the dopaminergic drug. And you can see on level 1, you had a 37% response. Level 2, 31% response. Level 3, 14. Level 4, 13. Still a substantial number, after all that treatment, didn't respond. So, that gives you some idea. And for many, many years now, long before all this sort of stuff, lithium was being used. By itself, it doesn't do much to depression. But the first augmentation of a tricyclic antidepressant was lithium and the tricyclic. And at the time, and I remember the studies, miraculous. You know, patients were getting well. They were going into remission. Whereas before, nothing was happening. And this just gives you some idea. Sorry, it's a very poor slide, this, but there's a whole number of studies written down on the left in different countries, different groups of psychiatrists. And what you'll see on the right is the changes which significantly favor lithium as an add on to an antidepressant, normally an SSRI, and then at the bottom you'll see the purple diamond, and that gives you some idea of the overall significance, and the statistics show it that by and large this was a very good combination for resistant depression. And it's still used. Lithium is an extremely cheap drug. And your SSRI antidepressants are cheap. And so you can combine them in even quite poor patients, or where you have a very supported mental health service. But lithium is a toxic drug. So one of our basic scientists will now tell us why lithium is a toxic drug, and psychiatrists must know this. Would you like to help us? Eva, if you use this, please.
Okay, I will try. I will start with knowledge that it has narrow therapeutic effect. So it inhibits GSK3. So I would call it that mechanism, because GSK3 is one of the basic and main intracellular signaling component. So, I think it gives it a dramatic effect, to my point of view, but I think I'm missing something else.
Okay. I mean, basically what you're saying, this is a drug which has effects within intracellularly and can affect many, many other processes, biochemical processes. But most important of all, lithium is what we call chemically an alkaline earth metal. And if you remember your chemistry, first, second year medical school training, you remember chemistry? How boring that was for medical students. It still is, don't worry, it hasn't changed. So you start with lithium, then you have sodium, and then you have potassium, and so forth. Now what's important, because chemically it's very, very similar to sodium and potassium, and all clinicians, including psychiatrists, know that sodium and potassium are absolutely vital for virtually every physiological process in the body. So when you give too much lithium, it interferes with every system in the body which contains sodium and potassium in a transport process. If you want to kill your patient because they're not responding well to your antidepressant treatments, give them a good dose of lithium. It'll stop the heart, they'll die pretty quickly. And unless it's a very smart pathologist, it won't be discovered, right? Okay. Being a pharmacologist does have advantage if you want to commit suicide. I shouldn't say that. Okay, so this is why lithium, always in psychiatry, you must take regular blood levels. And you can adjust those with a good psychiatric training according to the side effects, with the tremors and so forth. When that starts, that's as far as you go with that patient. Okay? So again, it's good biochemistry, good pharmacology, and good clinical observation. And when you do that, it's safe. Okay, now it's not a nice drug. You get all sorts of thirst, extreme thirst, and so forth. diabetes insipidus in the extreme cases, you know, where you're constantly urinating and so forth. It's not a particularly nice drug, but it works. Just bear that in mind. That was the first. Okay. Non-pharmacological strategies. ECT. As I say, personally, I think that somebody who's very depressed, and particularly if you have a middle-aged elderly patient, where you'd be very concerned about, because of the side effects, giving them a drug, an antidepressant. ECT works. And the modern method of administration is unilateral ECT, not bilateral ECT, which was the old-fashioned way. And unilateral ECT is effective with far fewer side effects causing amnesia and so forth, headache, etc. And this is the ECT which is applied in most European countries that use ECT. As I say, my country uses it. I won't say over-frequently, but frequently, in severe cases. And we really don't understand what it's doing. There's a few examples. You get all your neurotransmitters basically increasing, including your amines. And what I touch on later is glutamate. This is a method of increasing glutamate flux in the brain. And we think that is a very, very important mechanism now for the treatment-resistant patients. Again, GABA. Remember those two amino acid transmitters. Both are affected by ECT, particularly. Brain repair mechanisms are increased after ECT, and indeed after lithium too. Blood flow to the brain. Again, things that psychiatrists in most cases never think about. You have to get blood to the brain, you have to get glucose to the brain. So anything that affects glucose affects the brain. If the blood flow is inadequate for whatever reason, again, it affects brain metabolism and what happens to the psychiatric state. So these are things, it's no longer just a case of transmitters and sticking a chemical in to change them. All of these things are going on at the same time. And then your HPA axis, your hypothalamic pituitary adrenal axis, your cortisol levels come down. The feedback regulatory mechanisms are sensitized after ECT. Cortisol comes down, the stress hormone goes down. So it's a general change, produces a general change in the brain function. And it works better than most other treatments in treatment-resistant depression. Now, because of the stigma attached to ECT, you may not have met this in Turkey, but in Western Europe, 20 years ago, there was an enormous outcry and resistance to psychiatry. I was working in Holland at the time, and we could hardly hold a meeting on biological psychiatry without demonstrations outside and so forth. We're drugging patients etc. We're abusing patients. We're giving them nasty ECT. We're doing all these cruel things to patients. A senior colleague of mine, professor of psychiatry in the University of Utrecht, had bombs put under his car. He had the windows of his house broken because he was advocating modern scientific psychiatry very openly. That just shows you how things have changed. I hope you never saw that here. But when we had, I remember we had meetings in Berlin, big international meetings of the World Psychiatric Association, and there were demonstrations. We had to go through placard-waving people and so forth to get to the meeting. So psychiatrists were basically abusing patients. That's what we were accused of. But of course, that was the only way. We could get patients well, in most cases. They couldn't. It's changed. Thank goodness for you people, it has changed. But it was a very different world of psychiatry 20 years ago. Well, because of this sort of resistance still to ECT, we have this transcranial magnetic stimulation. Basically where you have a very, very strong magnetic field going across the brain. You have it here in Turkey, yeah? TMS? Yeah. So it does do things to the brain. It improves brain metabolism, particularly in the prefrontal cortex, which is one of the important areas in psychiatry. It increases monoamine function. It improves long-term potentiation. Long-term potentiation is the biochemical basis of memory, which of course is profoundly affected in major depression. And so you can see all these changes just with this magnetic stimulation. But if you look at the overall response, it doesn't compare with ECT. ECT is far superior. But if a patient does respond to this, fine. And then we have vagal nerve stimulation. Now, you remember from your basic physiology what the vagal nerve does. It's a very important nerve, particularly for the stomach, for the intestines, and so forth in the periphery. We now know it's extremely important in the brain. And, of course, you can't go and stick electrodes normally into the brain and do things like that. So what you do is you find the left vagal nerve, which goes up into the brain, and you can put a pacemaker to stimulate that. And so just as in cardiology you have pacemakers, so you can have a pacemaker to stimulate the vagal nerve. And again, one of the centers in Holland for research was in the University of Maastricht, where I was working. I've never worked on vagal nerve stimulation, but some of my neurology colleagues have been working on it. And again, there's been a whole number of changes which seem to be beneficial in some patients, but by no means all. And it's invasive. You have to implant the electrodes and so forth. So it's not a particular nice, shall we say, way of treating it, but in some patients it works. In epilepsy, in resistant epilepsy, particularly in children, it is fantastic. Nothing else works in these children with resistant epilepsy. I mean, terrible, terrible plight for a child. This works. So it's a method which has been introduced. And then we have deep brain stimulation, where you actually put electrodes into the brain of the patient. And again, with a pacemaker, stimulate those electrodes in the actual brain. Now, of course, it's not used very often, only for extremely severe cases where the patient is not responding to absolutely anything, including ECT. And again, if you look what it does, it's a very, very fundamental change within the neuronal metabolism and function. There are these ion channels for calcium and potassium and so forth, which are directly affected when you directly stimulate the brain in this way with these electrodes. And it seems to, if one looks at the imaging changes, the whole neuronal networks do change beneficially in patients that get well, and the majority do get well. But it means, as I say, you've got electrodes sticking into your brain, etc. So, it's not exactly something you'd want to do every day on all your patients. There's a very specific area of the brain which only responds, the so-called internal capsule, the cingulate cortex. We know from imaging studies and biochemical studies, these are the areas which are fundamentally abnormal in patients with depression. So you must locate, and these are very small areas, 1 or 2 millimeters, that's all. And if you don't get your electrode in those areas, you either get no response, or very often the depression gets worse and the patient becomes suicidal. So you really need a good neurologist and neurosurgeon to plant those electrodes precisely in the right bit of the brain. Otherwise, the patient gets worse. It's very chancy. So you can see we can certainly do things, but even then we get treatment failure. So psychiatry is a tough occupation, and you have to be a bit mad to want to do it, but it's the only challenge worth doing in medicine. So starting really from the beginning, discontinuation. Patients have got all these nasty side effects. You give an SSRI antidepressant. You tell your patient, go away, come back and see me in 2 weeks, 3 weeks. They go home, they believe the doctor, they take the drug, they feel nauseous, a bit more anxious, sleep's disturbed. They certainly don't feel like sex. I'm talking about male patients, by the way. And so I say, I'm not taking this stuff. I feel worse. And they don't tell the doctor. Discontinuation, failure. When eventually they see the doctor, no, doctor, I just feel even worse now, even worse now. They don't say, I've stopped taking it after 2 days because of the side effects. Treatment. Too low a dose, that's another big problem. Some clinicians are very, very cautious and conservative. Well, we give you just, instead of the proper dose of 200 milligrams, we give you 50 milligrams, subtherapeutic dose. Of course the patient doesn't get well. May not have side effects, but they don't get well. So that's no good. Non-compliance, that's very common. and particularly with long-term therapy, the majority of patients stop taking their drug, particularly when they start getting well. And remember, we're talking now not just in depression, but in schizophrenia, bipolar. These are chronic, often lifetime illnesses. We've done studies in the old days on sertraline, which was one of the very good SSRI antidepressants. And we had a group of patients on sertraline, maximal dose, for about 3 or more years continuously, having monitored beforehand, before they started, where about every 3 months, these were very severely depressed patients. They would go into a deep depression. In those days, we had to give them a tricyclic antidepressant, which are toxic drugs. You can't give them chronically, to get the patient back again to normal. Another 3 months, bang, depressed. By giving them the same dose of sertraline over a 3-year period, virtually no relapses. Some patients have been on now for 6 to 8 years with monitoring of an SSRI antidepressant, with very few going into relapse. So the recommended treatment of the World Health Organization, first episode, minimum 6 months continuous treatment. Second episode, minimum of 1 year. Third episode, lifetime. If you have a middle-aged patient who becomes depressed, by and large, for the rest of their life, they should be on antidepressant therapy. And this, whatever gets them well, keeps them well. Whatever antidepressant you give, and they get well, continue, keeps them well. Very simple rule. What gets you well, keeps you well. Write that down and remember it. What gets you well, keeps you well. Right across psychiatry. Misdiagnosis, very common. Depression is mixed up with anxiety disorders, often with bipolar, of course, which is part of it, the continuum, but which you use different treatments for bipolar than you would unipolar depression. So you have to look carefully at if a patient is not responding, they're taking their drug, carefully look at the diagnosis. You might have been wrong. And then you've got what we call a concurrent psychiatric disorder. I've mentioned particularly anxiety. Very, very seldom you find a very depressed patient without generalized anxiety disorder, or often it could be any of the anxiety disorders associated with the major depression. And this, of course, causes complications. If they have anxiety, they're less likely to respond to their antidepressants. So that has to be remembered. Always, always good clinical observation. That comes first. And then the drugs and so forth. Those patients who actually receive treatment for depression, I'm talking of major depression, 29%, 70% not treated. And look how that compares with all of the others. Look at that, blood pressure. 90%. Heart disease, 80%. Diabetes, over 90%. So forth. Cardiologists, you see, they know what they're doing. Everyone loves cardiologists. Nobody loves psychiatrists. It's only crazy people who become psychiatrically ill. So, and they don't count because they can't vote. So what the hell? I'm sorry, I sound cynical, but I feel cynical about the treatment of mentally ill people, and the mental health services are appalling everywhere. Do not be taken in by the wonderful things you see about American mental health service. It's bloody awful for anyone unless you're rich. So just remember that. That is a very important slide showing the differences, because there you can get accurate diagnosis. You have accurate markers of heart disease. It's a simple, very simple profession. Psychiatry is so damn difficult in comparison. And that shows here, 29%. You have a long way to go in your profession. So we have a whole number of medical and psychiatric disorders which can really cause problems and lead to therapy resistance. You really have to think very carefully, clinically, about your patient for this reason. I've mentioned anxiety disorders. If they've got severe anxiety and depression, the response to antidepressants is less. And therefore it's very important to do a proper psychiatric assessment at the beginning. Major depression, panic disorder, that's another very common thing. And your patient is housebound, terrified, going out, I'll be knocked down by a car or something like that. Or I'll be infected with something on the street. Substance abuse, extremely common. In Ireland, because of the stigma, particularly in the countryside, still attached to psychiatric disorders, we get young people. In my area, I'm living in the country, way out of Galway, in the countryside, farming communities and so forth. Just in a very depopulated area, farming communities, we've had 5 suicides of young people between the age of 15 and 22 in less than a year. 5. None of those youngsters have been near a doctor. None. And the reason? Because it's unacceptable in the countryside to have a psychiatric disorder. So what do the youngsters do? Drink alcohol. They get even more depressed. And under an alcoholic, jump off a bridge, hang themselves, shoot themselves, whatever. And I'm sure that happens here. It happens everywhere where you have a sort of an agricultural-based community where the understanding of mental illness is poor. It happens throughout Europe and everywhere. So substance abuse is a major problem, more sophisticated, taking cocaine, taking heroin, morphine, and particularly cannabis. Regular smoking of cannabis. I feel good as a result. But there are all sorts of biochemical changes produced by cannabis, particularly in the brain, which are detrimental to mental health. Schizophrenia, bipolar, depression. So substance abuse is something to always to watch out for when you're interviewing your patient. Oh, well, doctor, I have the occasional beer. What's the occasional beer? Well, 5 or 6 a night. That's the warning sign. Obsessive compulsive disorder, personality disorders, eating disorders. All of these coexist often with depression. Of those, the worst is probably the personality disorder. It is the real bane of upsetting contention to psychiatry. There's nothing you can do. Drugs don't work. Psychotherapy can. Long term, you don't have it, nor do we. Medical disorders, hypothyroidism, Cushing's, Addison's disease, involving the adrenals, diabetes, Parkinson's, all of these coexist often with depression. So you've got to pick them up. Interesting enough, hypothyroidism. You think that would be easy to spot. How many of you would think of looking at the thyroid system in patients who are just coming in and don't apparently respond to their antidepressant? You should check it. Yeah, subclinical hypothyroidism is common. So you don't get the full symptoms of hypothyroidism. Subclinical. And in a depressed patient, that stops your SSRIs from working properly. Give a little bit of T3, thyroxine or something, get the levels up again, the patient responds. Again, thinking below the neck. So, all of these things must be looked at before you say a patient is therapy resistant. That's the take-home message. It means good medicine, good observation. So there we are. That basically, if you're going to keep the drugs and you've been through all of this and you've decided this patient really is therapy resistant. So what can I do? Well, I've already mentioned most of these. Increase the dose, switch to a different antidepressant of a different class, which is why you have to know not just the drug trade name, you have to know roughly how it works. Okay? And you also have to know its different side effects too. So this is why your basic science comes in to your prescribing. Combine two antidepressants of different classes. Augment. And this really is I think, the way forward. Augment your antidepressant with lithium, remembering the problems, or with a second-generation antipsychotic. And the three second-generation drugs for which we have most evidence of efficacy are olanzapine, quetiapine, and aripiprazole. So there's now a lot of literature showing that combination with an SSRI or any other antidepressant. These are good combinations. Again, differences. Does it matter which of those three you use? Yes. Not because they don't work. They all work equally well or badly in patients with therapy resistance. But what is the problem long term in giving a patient olanzapine or quetiapine? What's a particular side effect that particularly causes female patients to stop taking those drugs? Yes, weight gain. Don't underestimate weight gain. Within the matter of 6 weeks, 2 months, they can put on kilos. Not all female patients, just some. And particularly a young female patient, the last thing they want to do is put on enormous amounts of weight, even though psychiatrically they're getting well. They know they're getting well, I'm feeling much better. But my clothes don't fit. I feel ugly. That's the last thing you want to do to a patient, make them lose self-confidence. You want to get them back and make them feel normal. Don't ever underestimate those side effects, and particularly weight gain. It's a major problem. That's where aripiprazole comes in, which doesn't cause weight gain. And that probably will be also true with some of the other second-generation antipsychotics, but we don't have quite so much evidence there. But aripiprazole can cause problems too. Some patients just don't like it because it causes a sort of dysphoria, and it's many patients it's not a particularly nice drug. But if they can tolerate it, it's a good combination. There we are. That's an overall summary of where we are with second-generation antipsychotics. And look, you can see, favoring the addition of the atypical. And look at the statistics are so good. And there we have olanzapine, risperidone, quetiapine, and also risperidone is another one which doesn't cause quite so much weight gain. So that's, again, something you've got to know. But you can tell. Just look up the general pharmacology of the second generations and you can actually pick the one. So we have scientific evidence. And that's what we always must have in psychiatry, scientific evidence where possible. And that's the summary. These are very complex drugs. You remember the old story? Well, yes, antipsychotics, what do? Well, sure, they block dopamine. They block dopamine. By God, they're much more complex than that. I mean, look at this. This is not the full story about quetiapine. And it has an active metabolite, norquetiapine. So you're not just dealing with one drug, you've got two drugs. And they have a different chemical profile. They do different things to the transmission. This is just a transmission in the brain, a few of the effects. This is damn complex. There you are. You've got antagonism, you've got partial agonism, and so it goes on and on and on. And changes in receptor sensitivity, etc. Again, you can simplify all this and say, yeah, sure, schizophrenia, well, yes, something goes wrong with dopamine, so we block the dopamine. Well, much more complex. Well, I'm not going into, that's just, quetiapine is a drug I've been quite interested in pharmacologically and that sort of thing, and it's a very, very complex and very interesting drug for the pharmacologist, but a clinician, okay, just remember, it's a good drug, a very useful drug. It does have side effects, but you don't need to know necessarily all this stuff about precisely how it works. But we're getting our hands on it. And it also affects particularly the immune system. I mentioned inflammation in depression and in schizophrenia. It's anti-inflammatory as well. And we think that could be very important in some patients. So I've mentioned these options. Other options. I put in there psychotherapy, stress relief, very important. And if one looks overall at all these wonderful things I've been telling you, if you just look over many years of these treatments, look at the bottom line, treatment-resistant patients that respond to treatment have an 80% relapse rate within 1 year. An 80% relapse rate. You've got these patients for a lifetime. That's what that means. So follow-up is essential. Fortunately, many of them who respond to a particular treatment will respond later to that same treatment. But just remember that. You've got your patient into remission, you've not cured them. You never cure them. Okay. Almost bedtime. I'm going to cut this right short. Let's say 10 o'clock. Is that all right? Because the bar's still open. Okay. And of course, I'm sure you all go to bed, as you should do. Why aren't there any new antidepressants? You know, we've got all these problems in psychiatry. We've got these wonderful drugs. Many of them don't work very well. What's the drug companies doing about it? Nothing much has changed. Nothing much has changed since the initial flush of drugs, all of which affect the monoamines. Nothing since then. And all of these wonderful drugs, not much to choose between them. Talk to any senior psychiatrist who's been in the trade for a long time. They have their favorites because they've always used it, but makes no difference what they give. Might work, might not work. So if they've all got a very similar profile, which they have, all were developed based on the idea that these three monoamines were the things that we've got to do something about, we're going to get exactly the same type of drug coming out. And that's what's happened. It's a bit bleak when you think about it. So the need for better and more effective antidepressants is absolutely critical. There's a whole number of reasons why. Side effects, drug interactions. I didn't mention drug interactions. Why is it important for psychiatrists to know about drug interactions? That's a nasty bit of complicated biochemistry, the liver and all that stuff. Why should you, as psychiatrists, care a damn about what other drugs your patient is taking besides the ones that you give them? Why? You should be thinking seriously about that. Any ideas? Any ideas?
Safety.
Safety?
Yes, long-term effects. It can be.
Safety. You mean another drug could make your antidepressant more toxic?
Maybe.
Maybe. Yes. The major problem with and you're right, the major problem with drug interactions is that the majority of your drugs, 80–90%, are metabolized in the liver. And there's a whole group of enzymes called the cytochrome P450 system, which breaks these drugs down. It doesn't only apply to psychiatric drugs. Remember, the majority of your middle-aged patients with depression are probably being seen by a cardiologist or by some other medical specialist and being given Other drugs, particularly heart drugs, which can be highly toxic themselves if the dose is not monitored. So if you have an antidepressant which blocks the breakdown, inhibits the enzyme which breaks down the cardiac drug, what happens to the cardiac drug? It remains for longer, it builds up. And if it's an antiarrhythmic drug, it blocks cardiac conduction, you've killed your patient. Who's responsible, you or the cardiologist? You. Because a drug like fluoxetine blocks the metabolism of the cytochrome P453A4 system, which will break down a lot of the cardiac drugs. You have to know this. If you don't know this, you are in trouble legally. You're responsible. This is what I mean. You have to understand the pharmacology of the drugs you're giving to your patient. It is not good enough to say, well, yes, the head of the team, the senior doctor told me to give it. It's your patient. The patient gets ill or dies. It's your responsibility. They're not senior doctors. Oh, I didn't look that up. He was on a heart drug. And the coroner says that's what killed him. You see what I mean? This is science. So you've got all those things there. This just really brings out why we have to have better drugs. So I think why we have limited treatment is because of the very poor understanding of depression and what we should be doing to improve brain function. So we need to understand more. We need more science in psychiatry. It's up to you young people. You've got to bring the science in. Us old guys are dead, brain dead. We won't do it. You, the young people, have got to say we're going to do it. Efficacy and acceptability, even of the drugs we've got. You know, there's enormous variation there. If we look here, there's fluoxetine right in the middle. And, you know, some are more effective and more acceptable. Escitalopram is the latest SSRI, which is now widely used, and so forth. But although they basically all have the same type of pharmacology, you can, to some extent, as I say, select if you know something about their basic pharmacology and their differences. It doesn't go far enough. So there's a whole number of things that we need and for the drugs of the future, which we don't have yet. And really, it's a long way to go. But we should be aiming for that. Yeah. So I want to sort of try and bring this now to a bit of a close, but if you look at the drug industry, and for 7 years I was working in the international drug industry. I was much younger, I was much better paid there than ever I was as an academic, had a lot of fun, and I was doing basic science, basically there, on antidepressants. My answer in metazapine, those were the drugs I was working on at the time. But every major drug company, which in the past was researching antidepressants, producing antidepressants, all have stopped producing psychotropic drugs, whether they be for the treatment of schizophrenia, bipolar disorder, depression, and so on. Stopped. Nothing going on. No research going on. They're getting more money from research into drugs for treating pain and those sort of conditions, somatic conditions, not for drugs treating psychiatric problems. Too difficult. So they're still pulling in billions of dollars on the old drugs. Many of them bring out generic drugs of the original. So there are, for example, Lilly is producing its own generic brand of fluoxetine, marketed differently, different trade name and so forth. Unless you know what you're dealing with, you know, you think, well, this is great, I've got a new cheap antidepressant. It's fluoxetine with a different package. This is why you don't use trade names. Look at the original chemical name. That'll tell you. When you go from Turkey to Holland to Germany, these are drugs with different trade names, all exactly the same as are sold here as the original. So, I've tried this for 40-odd years with medical students, teaching them, no, I will not allow you to use anything but the approved names. They go over to the hospital, within a year, they're using trade names, because the senior doctors use trade names and don't know the real name, the proper approved name of the drug. Education's a problem. Medical education's a problem. So drug companies are just not interested. They make more money elsewhere. And that's what drives them, not need. And this is why we have the problem. So there are approaches. I don't know if any of you have heard Professor Norbert Müller. He was talking yesterday and today and mentioned in the case of treating both schizophrenia and depression that if you lower the inflammation at the same time that you use an antipsychotic or an antidepressant, very often this leads to a positive response to treatment. Coming back to this whole idea that underlying these conditions is chronic inflammation. And so this is a new approach. Possibly we should think of targeting in the brain the inflammatory system. And there's a number of experimental studies from mine and other groups showing indeed that that seems to work. And maybe clinical studies are going to follow through. So there's a hope there. I've mentioned before that you can see how complex the inflammation is. And it changes in a whole number of very important clinical processes which affect the health of the patient, whether they be depressed or otherwise. All this is written up. And by the way, if you want to take copies of my slides, you can. That's fine. But don't copy them. You can just use them to read. I'll arrest you. I'll have you arrested if you did. Yeah, so, there are problems with anti-inflammatories. I'm not going into all this. But the last point is this whole glutamate thing. The most exciting breakthrough in depression research, again, came about purely by accident a few years ago. Ketamine. Ketamine is a drug which is what we call a dissociation anesthetic. It's been used since the 1930s. It basically counteracts pain in surgery. It produces, it certainly sedates the patient and reduces their consciousness and so forth, as any very good drug does. And it's being used, it doesn't suppress the respiratory center. So this is a very safe drug, and it's been used widely and still used to some extent in children. In adults, the problem with it is it can cause a sort of psychotic state. And most patients, understandably, don't like that. But children, for some reason, don't seem to, if they do experience it, they don't bother. Anyway, to cut a long story short, there was a study carried out by the Institute of Mental Health in the States by basic scientists, not by members of the drug industry, who used a low dose intravenously, which you have to give, of ketamine in very severely resistant depressed patients, hospitalized depressives, who hadn't responded to anything, including course of ECT. Within 24 hours, half of those patients went into remission for the first time in up to 20 years. Within 24 hours. After a single dose, that was maintained in a substantial minority of patients for 1 to 2 weeks after a single dose. We didn't believe it. This was impossible. Absolutely impossible. It was repeated. Controlled, double-blind, randomized controlled clinical trials, etc., etc. It was true. Absolutely true. It's now, I won't say it's not routine because, of course, it has to be done in a hospital. It has to be given intravenously. By law, in most cases, you must have an anaesthetist present and so forth. So it's a bit of a mess. But it's now used for treatment resistance in the UK, in Holland, in Germany, and many other European countries, and in the States. This is absolutely miraculous. So when we heard this, we thought, oh, what the heck is going on? Why? Why is it working? No other drug works like this within 24 hours. And anyway, to cut a long story short, again, like all these things, very complex, but it does not work directly on the amine system. It works via glutamate. It's a very complex action. Glutamate is a very, very complex neurotransmitter. It's got 3 major, what we call ionotropic fast transmitters. It has 8 metabotropic slow transmitters throughout the brain. All these are affected to some extent. Work that out biochemically in the brain of a human. So this, as I say, is the big breakthrough, and you know there it's being replicated and so forth, and it has a very complex action, particularly on the so-called ionotropic glutamate receptors, the fast receptors. It basically shuts down one and activates the other receptor, sort of a yin-yang balance, which the other antidepressants don't do. And that has a very potent effect on gene expression and on synaptogenesis, the way in which the synapse functions rapidly. And you can show it 24 hours. There are changes. So this is the stimulus for the future. We now need to be studying very seriously the glutamate system. It's difficult, but there are already potential drugs which have been tested, which to some extent simulate more safely ketamine. So the next generation of antidepressants, which only now are being taken up, of course, by drug companies, all the basic work was done by scientists. Important. There's a hope for us basic scientists yet. But there are problems, that's with ketamine, and also with any of these drugs that modulate the glutamate system. We have to watch out for abuse. People like ketamine. You know, it's a nice drug if you're a junkie. And there are problems, so you have to watch for that. And lastly, fish oil. That came up this afternoon in one of the symposium. From the floor, one of the psychiatrists was saying, you talk about treatments and so forth, but what about fish oil? Have you all heard about fish oil? Yes or no? All of you should be taking at least 1 or 2 grams of the polyunsaturated fatty acids from fish oil every day. And it will keep your inflammation down, it will keep your heart functioning good, keep your cholesterol levels down, and if you're suffering from depression, will help you to get well. It's an anti-inflammatory. So if you like fish, which I hope you all do, you should have at least 1 or 2 meals of fish a week. A fatty fish like salmon or something like that, but a good oily fish. Every week, 1 or 2 meals. Your psychiatric patients should be given little capsules of fish oil, at least 2 grams every day, with their medication. Every day, 2 grams. Yeah, every day, 2 grams. Do you have the German supermarket Lidl here? No. Lidl, yeah? Lidl have very, very good EPA fish oil. Very cheaply. It costs about, I think it's 2 euros for 1 month's supply. I take it. I've been taking it for 20 years. So this is a great source of medication. This is very cheap. Okay? So, sorry? Sorry?
Is it also beneficial for children? I'm giving it to my children.
Yeah. I don't... The only side effect I know of is if you take 9 or 10 grams a day, you may get a bit of diarrhea. That's it. I wouldn't recommend that, but, 2 grams a day. And it keeps the skin good as well, You don't have to put rubbish on your skin. You just take your fish oil. It keeps the skin healthy. Okay, so there you are. That's a very important take-home message. Everybody should be eating fish, and particularly your psychiatric patients. And one of my colleagues in Galway has been working on the biochemistry. And again, even dear old fish oil, as you can see, is pretty damn complex. EPA is eicosapentaenoic acid, which is one of the major components of fish oil, which is good for you. And it does a whole number of things. Look, it affects your inflammation processes. It even helps your monoamines. This is a brain-derived neurotrophic factor. It brings about brain repair. It enhances brain repair, damaged brain, which is what you got in depression. It lowers the overactivity of the hypothalamic pituitary adrenal axis. So but of course it's not an acute drug, it's not an acute. This is a supplement, it's a food supplement. Treat it like that. And so there you are, that's the last slide. Yes, we can still be a bit pessimistic, but I think in 10 years' time, your generation of psychiatrists will be dealing with a totally different type of drug for treating major psychiatric patients because of the introduction of neuroscience into psychiatry and into psychology. This wasn't drug companies. This was scientists saying, let's broaden the approach and bring in new ideas. And then drug companies come along, they can make the drug. But the ideas have to come from scientists, and particularly from clinical scientists, which is why we want to see more psychiatrists coming in, not just as psychiatrists, but also in terms of science. It's up to you, your future. So that's again, what's all that? Oh, pressing the wrong one. So how can advance? Well, again, there's a whole number of things I've already mentioned. What's your diagnosis? And certainly we need to improve and change our pharmaceutical industry. I personally can't see that ever happening. They're making literally millions and billions of dollars profit every year. If you want to speculate on the drug industry, you won't go wrong. And that's where they make the money, in spite of all the fact, our drugs, we have to charge a lot of money for the drugs for all the research we're doing. They spend at least 4 to 5 times more on their marketing than they do on their basic research into producing these drugs. Look at it outside. Who's paying for all that? You are. Your patient's paying for all that rubbish. They still make nice tea and they give you an ice cream, but still, that's not what it's all about. Okay, so, too late. Anyway, as I say, it was a very brief run-through, and the whole purpose of our workshops is not to really inform you a lot, but to stimulate you to educate yourselves. And it's so easy, and I completely have sympathy, and I understand, you're busy in the clinic. The last thing you want to do is to come back again, sit down with a book, or sit down with a new publication, or one of the psychiatric journals, and then spend hours every evening going through all this when you don't even have to do an examination. But it is absolutely essential to at least think differently about what you're doing. So if it's made you think like that, even just for a few weeks, then it's been successful. If it hasn't, you've wasted an evening, you've had a short break for your dinner, and you've missed the fun. So it's up to you to choose. Okay, folks, it's now 10:15. I hope you've had your money's worth, and I wish you well and to enjoy the rest of the conference, which of course is tomorrow. There's some very good papers. One I particularly recommend, talking about crazy ideas, a symposium on the gut-brain axis. Your bacteria in the gut, what you eat, what the food you eat affects the brain. Absolutely incredible stuff. And again, this is really going to be the sort of, I think, future to some extent, not only in psychiatry, but in terms of drug development. The bacteria in your intestines are producing changes, chemical changes within the brain. One of the big research groups is in Ireland, in the University of Cork, being run by two of my ex-students. Wonderful, unbelievable work. Clinical and experimental, but also clinical. So I think if you listen to nothing tomorrow but that, come and listen to the gut-brain axis. I really think the future, to some extent, is there as well. Now, 10 years ago, who would think in psychiatry, you actually think of your feces to affect your brain? But they do. That's it. Yeah. The mind boggles, but there you are. So, really, once again, science is fantastic. What's going on in neuroscience is wonderful. And I can assure, I've been in the trade now for nearly 50 years and still enjoying it. So really, if you're crazy enough to get into it, it would carry you right the way through to death. Not much else would. Okay, folks, off to bed, and I'm going to find the bar. And thank you for coming. Thank you for coming back. You've been very good. You've been very resilient and so forth. When I was your age, I'm sure I wouldn't have done it. But anyway, thank you.